That's a great question. So this study was based on preliminary data from a phase 1 clinical trial looking at Botensilimab and Balstilimab in patients with advanced chemotherapy-resistant metastatic colorectal cancer. And in that large phase 1 clinical trial, it was noted that patients who had liver metastatic disease did not respond to the combination of the CTLA-4 inhibitor Botensilimab and the PD-1 inhibitor Balstilimab in combination. Yet in patients without liver metastatic disease or without active liver metastatic disease, 23% of the patients had what we call an objective response, meaning more than half of their tumor decreased in size. And that preliminary data led to the study that we presented at ASCO. And the main reason for the study was to, number one, confirm the findings that we found on the phase 1, but more so also to identify what is the optimal dose of Botensilimab in this patient population. Because on the phase 1 study, both the 75 milligram and the 150 milligram dose levels of Botensilimab were associated with responses. And the second reason to do this study was to identify what is the contribution of Balstilimab, since on the phase 1 study, there was not a sizable number of patients who had Botensilimab alone, and the question arose whether, do you need to add Balstilimab to the combination of Botensilimab, to Botensilimab in that particular combination. Note that the question of PD-1 inhibitors such as Balstilimab had been answered over and over again in microsatellite stable colorectal cancer, and Balstilimab alone is not expected to result in any activity. So really, this was more of a contribution of component study, looking at Botensilimab alone versus Botensilimab, Balstilimab, and added also a control arm just for kind of standardization. So that's what led to the study. Now, as to the second part of your question as to why Botensilimab and what's different about Botensilimab. So as many of the audience know, there are two CTLA-4 inhibitors that are FDA approved. One is Ipilimumab, and the other one is Tremelimumab. And among these two, Tremelimumab had been combined with a PD-1 inhibitor in a phase 2 randomized clinical trial in patients with microsatellite stable colorectal cancer. And it had been shown on that study that the objective response in patients without liver metastases was only 2.5%. So, there's a tenfold increase in response in non-liver metastatic disease, again, with the limitations of the cross-study comparison for Botensilimab, Balstilimab compared to what had been reported with Tremelimumab, Durvalumab. Ipilimumab and Nivolumab has also not been reported to have significant activity on their own in patients with microsatellite stable colorectal cancer, although no formal large phase 2 trial had been conducted in that space, however. So I think historically speaking, the CTLA-4s that are available had not really panned out to improve responses or result in meaningful benefits when combined with PD-1 inhibitors in MSS-CRC. And therefore, the new generation CTLA-4 inhibitors, with Botensilimab being at the forefront and had been in development for the last 3 years in this area, or maybe even more. And what's different about Botensilimab is that it is a FC, we call it FC fragment enhanced or engineered. So there has been a further modification of the FC fragment of the CTLA-4, and this particular engineering, changes the activity of the molecule. It enhances T cell priming and activation. It activates antigen-presenting cells, and really one of the most important mechanisms, it enhances particularly the depletion of what we call Tregs or regulatory T cells in the tumor. So all of these together are likely at the heart of better activity of the CTLA-4 compared to what we have historically.